Hey everybody, how's it going? Hey everybody, how's it going?
I'm good. Can you hear me?
This is Richard that's talking.
This,
It sounds like his voice.
yes, this is Richard King from Chiron
Okay.
Physical Therapy.
Yeah. Brad, are you with us? Hey Brad, are you with us? Looks like we also have Natalie. Natalie, can you hear me?
I think so.
Excellent. Natalie, where are you from?
I am from Dubuque, Iowa, Dubuque Physical Therapy with Jason
Yeah.
Meyer.
Excellent. Excellent.
I'm not sure if I'm going to be able to stay on for all of it tonight, but I'm going to try for some.
Well, good. Good. Glad you could join us.
Great.
So how's everybody going? Had a good day?
Well, long day here, but yeah.
Okay. Well, good. Good. Well, welcome to tonight's webinar. My name's Dr. Brooks. I'm Vice President of Clinical Education for Hods. I'm board certified in both clinical electrophysiology and in orthopedics. I've been a PT for 30 years. Been doing EMGs for almost 25 years here now, 24 years. So guys, in trying to decide on a topic for tonight, what I had decided on looks like it might be something that's a little bit maybe more intermediate type level stuff. So I'm going to throw this out to you guys here. Would you guys want to proceed with what I had thought that I might do, or would you like to maybe take a step back and do something just maybe a little bit more basic? And keep in mind, when I do webinars, this is going to be interactive. Okay, so you guys are going to have to participate here. So you want to go something intermediate, or do you want to maybe take a half a step back and do something maybe just a little bit more on the basic level?
I'm definitely at the basic level. I'm not sure about anything.
Okay.
I think I agree as well on the basic part,
Okay. Let's
given the
let's
fact that
do.
I'm just now starting out.
Yeah. Yeah, but you're a pretty smart guy there, Keen. So you're going to be on my radar here. So, hey, Brad, can you hear me? Brad Brassfield, St. Louis. Can you hear me? Brad signed in, but he's not responding here. Okay, so let's see what I can dig up out of my Okay, so here's what we're going to do. I'm going to do a basic, what's called nerve conduction study waveform analysis here. And can you guys see my screen yet?
I can now.
Okay.
Yes.
So, so here's the rules. Okay. I'm going to show you a waveform, and it may be a sensory nerve waveform. It may be a motor nerve waveform. It might be, it might be an H reflex, something like that. So what you're going to do, and Natalie, have you been to any of the trainings yet?
I have been to no EMG.
Yeah, okay, so this is
I've,
all new to you. So I'm
yeah,
gonna write myself a mental note not to be too rough on you.
I'm gonna be clueless.
Okay, so again, I'm gonna show you a waveform, and you're gonna look at it, and I want you to analyze what you're seeing. Okay, uh, things such as, does it have the appropriate morphology? Does it look correct? Are there cursors in the right spot? Is the baseline stable? Is there any artifact that may be hindering your ability to properly analyze that waveform? And then any other technical stuff that you think might be appropriate here. And then at the end of that, I'm going to ask you, is this a go or a no go? Okay, in the military, when you were assigned a task, and when you were graded on that task, you were given a go or a no go. Okay, so let's go ahead and begin. Here, it looks like we are recording, so let me make my screen larger here. So here we have a sensory waveform, and this looks, by the fact that it's being recorded out of the lower leg, stimulating in the lower leg. This is probably a sural nerve waveform. Okay, so take a look at it and tell me what you think. And again, Natalie, since you've not been to a training, since you've probably never seen this, just just sit back, observe, and of course, if you have any questions, be sure to ask here. So, Richard, since you're the only one here that's been to trainings, done really well, and has the ability to communicate with me, tell me about this sural sensory response.
Well, we have artifact in the beginning.
We have what's called stimulus artifact.
Yeah.
Okay.
And I'm not crazy about the baseline.
We have some 60 cycle interference here.
Yeah. Mm-hmm. And I think between the stimulus artifact and the baseline, you're really only getting that return to a baseline. You're not really getting an accurate rise of the wave.
Uh-huh.
And I think that may make it difficult for cursor placement because you don't know where the baseline should be.
Sure. And the good news about these sensory waveforms, the latency is based on the peak here. Okay, so we certainly can get a peak, but placing an onset becomes a little bit more difficult. So certainly with this waveform, we would want to see if we could clean this up. Okay. Usually when you see a big stimulus artifact like this, that means your shock intensity is too high. And probably if we drop down the intensity some, and if we rotate our anode, that could potentially clean this up here. So just seeing this, Richard, would you be happy with this?
No.
Yeah, so you would give this a no-go then, correct?
Correct. I would shock it again to see if I could get a cleaner waveform.
Yeah, I would totally agree. I would not be happy with this waveform, and I would attempt to get this thing cleaned up here. Okay, so here's our next sensory waveform, and again, guys, all of these are pulled from actual patient reports that get sent to me. Okay, so this is a median sensory. we're stimulating first at the wrist, and we're recording off of either digit 2 or digit 3. Then we're stimulating in the palm here. Okay. So take a look at this and analyze the quality of the waveforms, or in this case, waveform. And then look at the big picture and tell me if you think this would be appropriate or not appropriate.
Me again?
It's going to be you and me, brother.
Okay.
And Madly, again, feel free to ask questions. I'm gonna unmute you. Well, I can't unmute you because you muted yourself, but feel free to ask questions.
Okay, that'd be fine.
Okay. So, Richard, okay, this top tracing, does that look okay?
The baseline is okay to me.
Yeah, I would agree.
With 2 microvolts, I would expect that wave to be slightly larger.
Yeah,
like
we're
with the
at
bank on there.
20. Yeah, we're at 20 microvolts per division here. So this is probably about a 15 or 16 microvolt response. Which again is within our normal range.
Okay.
So this top waveform actually looks pretty decent here. But what's happening here? How is it possible if we're recording off of, say, digit 2 or digit 3 and we shock at the wrist and we get a waveform? How is it possible that we don't get a waveform when we shock in the palm?
We're not shocking the nerve. We're shocking the wrong location.
We're obviously not depolarizing the nerve, because there's no way in heck that you could get a response shocking at the wrist and then move closer to the nerve and not get a response. Okay, that's just not possible. Just not possible. Okay. Now, if this was flipped, if this was the wrist and this was the palm, that certainly could happen. And what do we call that?
Conduction block.
That would be a conduction block. Exactly right. So, Richard, would you give this a go or a no-go?
No go.
It's a no-go, simply
at least
because,
for the palm stimulus.
Yeah, because we don't have a waveform here in the palm. We should have a waveform in the palm. This waveform here is perfectly okay. That this is a high quality, sensory waveform. But the fact that we're not getting in, anything in the palm, just blows us out of the water here. Okay, so this is a radial sensory waveform. Take a look at this and give me your thoughts.
Your onset cursor's off just a little bit. I would back it up just a little bit because of the initial.
To be absolutely totally anal, it probably should go about right there. But at 20 microvolts per division, that's going to maybe mean a difference of 2 microvolts, which could make a difference there. But overall, how about the quality of this waveform?
That looks good to me.
It's beautiful. And we've had a couple of people join us here. We got Brian Cochran joined us.
Good evening.
And Ben Larson also joined us from beautiful Wyoming. Brian is in Covington, Louisiana. So yeah, this is a beautiful sensory waveform. I would take this 100% of the time. And what makes this basically perfect is we have a baseline prior to the waveform. We have a nice smooth baseline after. We have a beautiful, sensory nerve response. And this little bit of stimulus artifact is not affecting this on a baseline. If we were shocking at a higher rate, at a higher intensity, most likely what would happen is this would drop even lower and then meld into the actual waveform here. So this is as beautiful a waveform for a sensory nerve as you can get. Brian and Ben, Vicky Buchanan. Vicky Buchanan has joined us here also. Hi, Vicky.
Hey, can you hear me? This is actually Mark.
Who is this?
This is Mark. Can you hear me?
I can hear you.
Okay. Yeah. Anyways, long story. I'll
long
tell you
story.
later.
Okay.
Happy to be here. It took a little bit.
Excellent. Guys, this is interactive. Basically, what we're doing is I'm showing you some waveforms that I've pulled from some recent reports that have been sent to me, and we're analyzing them for quality, and then we're giving it a go or a no-go on whether these are acceptable, or not. Okay, so this is about as technically beautiful in a waveform as you can get.
Yeah, looks good.
Okay, so here we're going back to a median sensory again. Top waveform obviously is when we stimulate at the wrist. Second waveform is we're stimulating in the palm, and we're recording either off of digit 2 or digit 3. So guys, take a look at this, these waveforms, and give me your comments.
Well, the onset on the top one is not in the right spot.
I would agree with you. And since you bring that up, where should it be?
Yeah, well, it should be right there from the first deflection.
Yeah, it should be right where my cursor is, right here. See if I can't draw here. Should be right there.
Yep.
Okay. We got a little bit of stimulus artifact here, got a little bit of squirrely baseline. Patient could have been moving a little bit, or, electrode, could be coming off, but, we have enough here to get a pretty good reading. How about the second one here? Tell me what's going on here.
A lot of artifacts.
Yeah, what type of artifact?
There's definitely some stem artifact.
Yeah, this is stem artifact here. Okay. And, stem artifact usually occurs, you see it mainly in sensory nerve tracings, and it occurs when the stimulus intensity is too high and your stimulator is too close to your recording electrode. So by protocol, the recording electrode is 7 centimeters from your stimulator when you're doing a palm stim, and it's 14 here, and it's 7 there. And because it's so much closer, the waveform, the onset for that waveform, becomes affected by that stimulus artifact. How do you fix it?
You draw an imaginary line of the baseline back across the waveform.
But Richard, how do you fix this? How do you get rid of this?
Or you can decrease your stimulation.
Yeah.
As long as it doesn't mess with your amplitude.
Yeah, chances are what happened here, they stimulated at the wrist here first, okay? And to push that action potential over a 14 centimeter segment requires a little bit more intensity than it does when you go in the palm. And most likely what happened is when they went in the palm, they didn't drop their intensity down. they kept it at the same intensity. Okay, and got the big stem artifact. And then because they got a waveform here, they just stopped. And the question is, where do you put your onset cursor? Okay, I'm not comfortable putting it there because we have some motor artifact occurring here also. It certainly is not correct there.
Yeah.
Okay, I mean the amplitude, if we're at 1, 2, 3, 4, almost 5 units, the table's going to say the amplitude here is probably 100 microvolts, and that's not realistic. We're at 1, 2, we're at 25 microvolts roughly here. We're at 100 here. Somebody's going to call that a conduction block. When it's really not a conduction block, it's a technical error due to a high, stimulus causing a stimulus artifact. There's a little itty bitty hitch right there where you could probably, put your onset cursor. That would make it about the same height as this, but you need to try to clean this up first. So, this is acceptable. I could live with this, but, I certainly would want to see this cleaned up. This is an ulnar sensory waveform. Anybody want to comment on this?
It's hard to find the baseline. It's kind of got a slow rise to it.
Yeah, the baseline is probably doing something like that.
Yeah. Yeah.
Okay. So is this onset cursor, is it in pretty good position?
Not bad.
Yeah,
Not bad.
it's okay. Yeah. You could maybe put it here, or you could maybe put it there, but again, at 20 microvolts per division, moving it a little bit this way, a little bit that way, is not that big a deal unless with it there, the amplitude is, say, maybe 9.8 microvolts when normal is 10. Okay. And unfortunately, I actually see that quite a bit. That I'll see a sensory axonopathy called in an impression because the amplitude, the measured amplitude is 9.8 microvolts and the normal is 10. And when I see that, the first thing I do is I would move that onset to here, and that's going to make that response normal. Okay, we're always looking for normal, just like when you're doing ultrasound. Okay, you want to be familiar with normal. You want to look for normal. Certainly, we're never ever going to call it sensory axonopathy based on a 0.1 or 0.2 microvolt decrement on this, because chances are if I did a second run on this, I could probably get this thing to 12 or 13 or 14 or 15 or something like that. So overall, is this okay? Would we give this a go or a no-go?
Give it a go.
Yeah.
Give it a go.
Yeah, I'd give it a go. Here we have a radial sensory, and I see this a lot also. Okay, so can anybody comment on what's happening here?
And some stem artifact at the beginning.
Yeah, we got some stem artifact here again. It's presenting in a little bit different way, but we certainly have some stem artifact here. And what is that stem artifact affecting?
It's affecting our baseline.
Yeah, it's affecting our baseline pre-waveform. And so the question is, my guess is the baseline is probably
Yeah.
somewhere here, and we have our onset cursor. The machines put the onset cursor there.
Yeah.
Okay.
It looks like there's a little motor artifact afterwards.
There is. There's a little bit of motor artifact here, but that's okay because we got this little straight stretch here.
Yeah.
Okay. We got this little flat area here. So again, how do we clean up a stimulus artifact?
Decrease intensity.
Decrease intensity, and then what's the other technique that you can use? Rotating the anode.
Yeah, rotate the anode.
Yeah. So probably with just a little bit of work, this could be cleaned up, and we'd probably get a nice baseline right in this area here. So as this stands, like we see it here, is this okay? Is this a go or a no-go?
No-go.
It's going to be a no-go, because what if on the other side the onset cursor is here? It's going to show probably about a 50% difference, from side to side, and it's going to pop up the dreaded red box of death, and somebody's going to call a radial sensory axonopathy. That's not there based on a technical error and based on the fact that your onset cursor is just not in the right position.
Well, if you did that on the uninvolved side, and you had the O or the origin where they have it right there, and then compare it to the involved side, if you're seeing like is it a 50% on sensories?
Sensories, yeah. Sensory 50% difference from side to side.
So it's plausible. It could be enough in the trough that you may say, oh, that's compared to the contralateral side. If for some reason you did it on the contralateral side, it might show up as a 50% drop on your symptomatic side.
Absolutely. And again, like I said, unfortunately, I see this a lot. One of the things that I try to preach to people is, as you generate that waveform, analyze it. But before you even think of moving on to your next sensory nerve test, analyze it. Take a look at it. Make sure you've got good data. Make sure your cursors are in the right position. Okay? And then, and only then, go ahead and move on. Because what really sort of sucks is when somebody like me or Dr. McKibben or somebody says, oh, yeah, this is not good. Call the patient back and bring them back in and redo it. Okay. So Natalie, as you learn to do these techniques, what we're going to teach you and what your mentor is going to insist on is that as you generate any waveform, be it a motor or a sensory, before you move to the next test, you're going to look at it. Okay. Does it look like this or does it look like that? Okay.
Yeah.
So is there artifact? Do we got a stable baseline? Are cursors in the right position? Okay. So if yes, there's not a lot of artifact, if we got a good baseline, if cursors are in the right position, then we're going to analyze latency, we're going to analyze amplitude, and we're going to analyze conduction velocity. And then and only then do you get to move on to your next nerve. Okay, so we've gone back to the median nerve here now. How about this? Is this okay?
Yeah.
Yes.
I don't love the second one in the palm, but I'm
because of the stem artifact.
Yeah, that, and to me, it's hard to tell exactly where the deflection is at.
Yeah,
where the onset should be.
Yeah, again, it's going to be right in this area here. The good news about sensory waveforms. What's the only parameter that the onset cursor affects in a sensory waveform? Amplitude.
Yeah.
Okay, so moving it here versus here versus here, it's going to affect that amplitude maybe by 1 microvolt. Okay?
Yeah. Okay.
Yeah. So, unfortunately, because the second waveform is being done, like I said, at 7 centimeters.
7. Yeah.
oftentimes you're going to get more of a stimulus artifact, and if I had done this and I got these results, I would be happy with them. Okay, because again, I've got enough good, smooth baseline here prior to the response, that I can put my cursors, into the right position. This one up here, if
Dr.
I was,
Brooks, I guess that's would that be where you'd be more concerned if it was a motor? I mean, obviously you wouldn't do a motor, but
absolutely.
okay, I think that's where I was getting off. I'm sorry.
Yeah.
That's what I was thinking.
But the good news about motors, because they're so much, I mean, they're 1,000 times larger than a sensory waveform. We don't get the stem artifact. Okay,
Right.
and maybe as we go on, I can show you an example of what happens with a motor, when you overstimulate at that most distal stem site. Nitpicking, I could maybe move this peak cursor that way, maybe by about 1 notch. Okay, but again, overall, in terms of the quality of the waveform, I would take this, 100% of the time. And here we go. Okay, so now we've gone into some motor waveforms. Somebody tell me what nerve we're testing here.
Testing
Fibular.
fibular.
Common fibular, common peroneal. Okay, and we know that because we have an ankle stem site, a below fib head, and a popliteal. Okay, so getting back to the whole stem artifact thing, this is what happens with a motor when you overstim. Instead of that nice smooth baseline, you got this little curve deal. It can curve down like that, or it can curve up like that, or you can have this little trough. And that'll make it difficult to place. Let me see if I can't. Yeah, it would make it difficult to place our onset cursor. Here, at least, we can at least see where the waveform takes off. Okay, so I think we've got good cursor positions here and here. Then we get up to the popliteal area and we stimulate and we get this right here. Okay, so what's happening here?
Getting the wrong nerve.
Yeah, well, what nerve are we getting?
Tibial.
We're getting
Tibial.
tibial nerve. Okay, either we've overstimulated to where we've gotten peroneal and tibial, or our stem probes are in the wrong position and we're directly stimulating the peroneal, or excuse me, the tibial nerve. Okay, what muscle are we recording off of with this test?
EDB.
Extensor digitorum brevis. Okay. If we're recording off of the extensor digitorum brevis, which is a peroneal innervated muscle, how the heck are we getting a response when we stimulate the tibial nerve? How is that possible? Even possible?
Your stem intensity is so high, you're getting volume conduction.
Getting volume conduction of what, Brian?
Tibial nerve.
You're
What?
you're catching some of the peroneal, you're catching some of the tibial, you're catching.
Yeah, but we're recording off of muscles. So what's happening to give us this response? You are absolutely correct about the volume conduction.
That tibial nerve.
Yeah, well, what's
The
the
tibial nerve does every other muscle.
Yeah, it does. It does all the others. Yeah.
yeah, what's the only muscle in the foot that is not innervated by the tibial nerve?
EDB.
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 EDB. So what's happening is you're firing every other single intrinsic foot muscle, and you're getting this large volume conducted response. And I wish I would have put the table in here. You can see that the onset latencies here are nearly identical. Anybody want to take a guess what the table showed the nerve conduction velocity at from knee to fib head?
175.
At least 90 to 100.
114 meters per second.
It's sped up.
That's a very fast nerve conduction velocity. No nerve in the human body conducts at that speed.
Maybe the flashes nerves do.
Yeah.
Yeah. There's a couple of nerves. The radial nerve, routinely will conduct at about 70. Might even in the axillary region might even get up to 80. But in the upper extremity, the normal nerve conduction velocity for a motor nerve is 50 to 60. In the lowers, it's 40 to 50. Anytime you see this,
In general, Mark, you know that you're getting the volume conduction if the shape of the waveform changes, right?
the shape of the waveform has completely changed. Not only has it changed, it's probably more than twice the amplitude of the true peroneal waveforms.
Dr. Brooks, another question on that. If you were,
I'm sorry, go ahead.
if you were getting that, besides reducing your stem intensity, if for some reason you still couldn't get it, and I don't know if that should be a thing, would you consider switching it to the tibialis anterior for the last one, or would that?
I would, first thing I would do if I went from fib head to popliteal and I did not increase my intensity and I got this, first thing I would do is I would move my stimulator lateral.
Okay.
I would come way lateral. I would come just inside the tendon of the short head of the biceps femoris.
Okay.
And about 90% of the time, that will clean this up.
Okay.
If it's still a little funky looking, then I would reduce the intensity, and what will happen is you'll see it change into this as you reduce that intensity.
Okay, thank you.
Okay, so there's no fixing this. There's nothing I can do in terms of moving cursors to fix this. When I look at the SD file, okay. Unfortunately, the only option is what? It has to be yeah, you got to bring the patient back in, okay? And that sort of sucks. After you've done that once or twice, you sort of learn not to let this happen here again. Okay, so here you've got a couple of beautiful waveforms. What nerve is this?
Tibial.
Tibial.
This is the tibial nerve. These are beautiful waveforms. What's wrong with this?
Onset.
Onset, definitely.
Yeah, so where does the onset cursors need to be?
First deflection.
Yeah. Here, again, we're probably overstimulating. Okay, we see some stem artifact, and we don't have the nice baseline. We have a baseline that's sort of sloping up. Okay, so do we put our onset cursor here, or do we put it here, or do we put it here? Okay, this one here is easy. It's going right there. Okay, but here we're getting some stem artifact. It's affecting the integrity of our baseline. I would probably end up putting it right here. Okay, chances are if you put it out this way too much, you're going to end up with a slow NCV. Okay, there's going to be a bigger latency difference here. Okay, what else is happening here? That is very, very common in the tibial nerve.
Positive deflection, or?
That okay, and again, why are we getting a positive deflection when we're pulling off the abductor hallucis?
Is it because of the foot muscles getting beat up, or would it be something else?
It's volume conduction again.
Okay.
The whole foot is a volume conductor for the tibial nerve. Okay, so this positive deflection could be due to that. It could be due to the fact, like you said, I don't think the abductor hallucis is beat up too bad because we got these beautiful amplitudes, but we could be off of the motor point also.
Yeah. So you'd
Okay.
move the recording electrode then?
I wouldn't even do that. I would just move my onset cursor to here and to here. Why do we see a drop in amplitude when we shock at the ankle versus the popliteal region? I had a report last Friday where the person called a conduction block, called a 30% conduction block of the tibial nerve in a 6'4" guy that had a 46 centimeter segment. Why is this amplitude dropping?
Yeah, to me it looks like there's an increase in duration.
There is an increase in duration. Absolutely, there is.
Which increases the area. So yeah.
Well, it doesn't.
Dispersion.
It doesn't decrease the area; it decreases the amplitude. Okay?
Well, I said yeah, right. Sorry.
Yeah.
Yes.
So so what is this called?
Temporal dispersion.
This is temporal dispersion, which is very, very common in long segments of nerves. The nerve that you're almost always going to see some temporal dispersion in is the tibial nerve.
Dr. Brooks, would you see that like even in a 5'1" diabetic or anything, like a big lady or something like that?
Great question. Great question. Yes, because there is pathologic temporal dispersion. As you kill off some of your axons, the disparity and the synchrony changes, and you could see an increase in that duration, pulling down that amplitude due to a demyelinating or an axon loss process. So yes, there certainly are conditions in which you can see abnormal or pathologic temporal dispersion.
But you wouldn't see a normal temporal dispersion in someone of that height, correct?
Probably very minimal. I mean, you might see 10%, 15%, maybe even 20%.
It wouldn't be common though. Okay.
Yeah. So as this sat prior, let's see. Yeah. As it sits right there, is this a go or a no go?
To go.
No go.
This is a no go.
No go.
No go. Our onset cursors are in a no position, and this is easily fixed by moving them. What nerve is this?
Median.
Median nerve. Yeah. How about these waveforms? How about these cursor positions? Go or no go?
Go.
That's a
Go.
Anybody say no go?
No.
Yeah, I take this 100% of the time. Same nerve.
Yeah.
Okay. Other arm. What's happening here?
You're getting some ulnar nerve involved.
Oh yeah. Yeah. And what makes you say that?
The double hump.
The morphology.
You've got a change in morphology from that to that, and what else?
There's a positive deflection.
Positive deflections here. Yeah. Okay. This is a textbook ulnar looking waveform. We look at ulnar C-maps like we look at camels. We look for humpage here. Double humpers here. So what do you think, most likely, seeing that there's minimal stimulus artifact here, what are a couple of possibilities that would cause this.
Of a Martin Gruber or
Oh, okay. So I'm going to say 3 possibilities then. Martin Gruber certainly could be one.
He could be off the motor point.
Yeah,
He or she.
yeah. The recording electrode could be a little bit too medial in towards the palm of the hand, or
Or it could be an ulnar hand.
it could be an ulnar hand, but that's sort of exotic.
Right.
You
Yeah.
know what's a simple technical thing that could cause this?
positioning, you're on the ulnar nerve instead of the median nerve.
Yeah. You're allowed your stimulator to go too medial, and you're shocking the freaking ulnar nerve. Okay, so just like the foot is a volume conductor for the tibial nerve, the hand is a volume conductor for what nerve?
The ulnar nerve.
The ulnar nerve. Somebody tell me what the only muscles in the hand are that are not ulnar innervated.
It's abductor pollicis, flexor pollicis, and what the opponents maybe, or I'm
Okay,
trying to
and what else?
First interossei.
Lumbricals.
First and second lumbricals.
Yeah.
Okay. Abductor pollicis brevis, opponens
Yep.
pollicis, and 1/2 of the flexor pollicis brevis. Everything else is in a normal cadaver. Everything else is innervated by the ulnar nerve. Okay. Now somebody brought up the concept of Martin Gruber here. And again, that's way beyond the scope of what we want to talk about tonight. But, Martin Gruber is a median to ulnar or ulnar to median communication in the forearm. What do we call an ulnar to median or median to ulnar communication in the hand?
Reach canoe.
A Riche canoe. Yeah.
Canoe.
Yeah. Up to 18 to 20% of cadavers have a Martin Gruber. What percentage of cadavers in some studies have shown a Riche canoe anastomosis?
It's ridiculously high. I can remember that.
75 to 80%.
Oh wow.
Yeah. 75 to 80%. Okay, so again, we realize how complex and how technically good you have to be to do good nerve conduction studies. Guys, EMG is easy. If you know where the muscle is and you can get the needle in the muscle, EMG is easy. Okay? Getting good waveforms during nerve conduction, especially in a sick patient, I think is way more difficult and prone to error.
And that's interesting that you say that, because I just got back from the state legislature on can we do this in Wyoming as an expert witness. And the medical is all fighting the EMG. They don't care about the nerve conduction side of things. They're saying the EMG is too technical for us to be doing versus the nerve conduction.
Yeah, so why aren't they fighting us about nerve conduction?
I don't know.
Because all these freaking neurologists have technicians
Yep.
that do their nerve conduction tests.
And
those
the other argument I had tonight was PTs can't do them because the tests are too painful, and to do the test twice is unacceptable if they were to refer them on to a neurologist if they saw their other pathology.
Yeah.
There's really interesting arguments that it's not about the technical proficiency of a PT, it's just a turf war type.
Well, it is a turf war.
Communication.
Yeah, PTs do a way better job of this testing than a typical neurologist. I mean, I've got a stack of neurology EMG reports that at some point I might share in a webinar. They're horrific. They are horrific, awful, terrible. Okay, Kathy Blair sent me one last week where the guy did. This was the extent of his test. He did a motor and a sensory and stuck 3 muscles.
Yeah.
And he said, he was able to rule out everything by doing a motor and a sensory and sticking 3 muscles.
That's one we argued tonight too, was that specific test.
Oh, so did she bring it?
No, we discussed how it was a discussion. She wasn't there. I was
Okay.
I found out about this at 1 o'clock today, that they were pushing our bill through for open
Direct access.
More open access, and as part of it, the physicians wanted to stop us doing EMGs as part of this bill. Well, it ended up going through, so we're good for right now. I mean, once it gets on the Senate floor, there's going to be probably more discussions, see if there's going to be more.
Well, good.
On what's happening.
And you guys need to stay on top of your senators.
Yeah.
And make sure that some advocate for the AANEM or the ANA doesn't get in there and get them to change their mind. Okay, so is this a go or a no go?
No go.
This is a
No
no.
No go.
Yeah. Cursors are in the wrong position. They should be here and here. Waveform morphology is incorrect. So this could probably be fixed most likely by moving the stimulator maybe 1 or 1.5 centimeters more lateral, and then it would end up looking like that. And it's really cool. Take the time sometime, when you're doing this on somebody in your clinic, shock the ulnar nerve, then go over and shock the median nerve, and then go over and shock the ulnar nerve, and watch these waveforms change. What nerve is this?
Ulnar.
Ulnar nerve. Mm-hmm. Most likely this is off the FDI, but again, you've got the whole double hump thing happening here again. Okay. So, anything wrong with this?
It looks good.
Yeah, it looks good. Looks like we have a little bit of an amplitude drop when we get above the elbow, and I think there was like a 19% drop or something like that. But again, we're looking at the technical component. There's virtually no stem artifact. Beautiful baselines. Very easy to put your onset cursors into the correct. So this certainly would be a go here. So it looks like we got a median nerve here. Okay, so what's happening here? And this one's a little bit more tricky.
Yeah, I think it's starting to get in the ulnar nerve a little bit, because that amplitude increased and it's starting to peak a little differently.
Well,
that morphology is a little different. It's
not starting; it's completely changed shape there.
Yeah.
Yeah. So if you technically went back and you're 100% correct that this is what you're getting, where's your next stem point going to be?
The axilla, or
no? If you stem on the axilla, it's
Come
going to
back
look
and
just
go
like this.
like mid forearm.
What's that?
Come back and go about mid forearm.
No,
that could be a Martin Gruber where
this is a Martin Gruber, but you're not going to shock in the mid forearm.
Go to the ulnar.
Where are you going to shock to prove that this is a Martin Gruber?
Oh, okay. Yeah, you will shock the ulnar.
Yeah.
You'll shock the ulnar nerve where?
At the elbow.
No.
At the wrist.
No, at the wrist. You're going to shock the ulnar nerve at the wrist, and you're going to get a response that looks like this. It's going to be smaller than this, but when you add, it'll look something like that. And when you add this amplitude to that amplitude, it's going to equal this amplitude. Okay, so again, talking about the intricacies of Martin Gruber is beyond what I want to do here this evening. But if you're testing the median nerve and you see this, to prove that it's a Martin Gruber, you're going to shock the ulnar nerve at the wrist. What if you're doing the ulnar nerve? You've shocked at the wrist, below elbow, and above elbow, and you're suspecting a Martin Gruber. Where's your next stim going to be?
At the median nerve at the
median
wrist?
at the wrist.
Median nerve at the elbow.
Okay.
At the elbow. Okay, and Richard, this is something that you're going to learn. Okay, and it's best learned by looking at what these nerves are doing in the forearm, and once you see that, you'll understand why when you're doing a median motor test that you're going to shock the ulnar at the wrist, and while you're doing an ulnar motor test, you're going to shock the median at the elbow. Okay, so again, these look like pretty good waveforms. Cursors are in the right place and everything. A little bit of a positive deflection here, which is going to be your giveaway. That something's brewing here. Okay, there's a little something going on there. No stem artifact, so you're not overstimulating, but you're still getting a little bit of the start of a positive deflection, and that's going to tell you that there's a little something going on. Then you shock at the elbow. You don't stop there. Unfortunately, the young lady that did this test is going to have to bring this patient back and redo it. Okay, here. Okay, but again, this technically is okay, but we don't know if this is technical error until we shock, until we do that third stem site there.
Hey, Dr. Brooks,
Yes.
when it comes to positive deflections, besides being off the motor point and something such as this, an anomaly such as Martin Gruber, are there any other reasons for positive deflection? I'm trying to think if there are any more.
Yeah, typically, what a positive deflection means is that your recording electrode is not at the point at which the waveform is being generated. Okay? So it could be that in this case, it could be that you're off the motor point, or it could mean that part of this waveform is being generated by an ulnar innervated muscle, and you're getting that.
Okay. Thank you.
Okay. Okay, so I got this yesterday, last week. So yeah, this is and again, they did this nerve. They only did it on one side. Okay, so this is a suprascapular nerve test recording from the supraspinatus. So obviously, there's a lot of stuff here we can discuss. Natalie, with this nerve here, you're actually shocking the brachial plexus, and so we have a big stem artifact here. And look at our baseline. How our baseline is just sort of curving down there. Okay, we don't have that nice baseline. Okay, so that's an issue. We can sort of maybe put a cursor here, but looking at this, this doesn't tell me anything unless I have the other side compare to. And there's certain groups of nerve tests that are always done bilaterally. Okay, axillary nerve, musculocutaneous nerve, suprascapular nerve, spinal accessory nerve, long thoracic nerve, femoral nerve. They're always done side to side, so you can compare affected to, unaffected side. So just looking at this by itself really doesn't tell me anything. Okay. What if we did the other side? I mean, this amplitude was normal, that latency was normal, but what if the other side was like this? What if the other side had 3 times the amplitude? Then we would have some data that we can analyze. Then we could say, oh, there's a major amplitude disparity from side to side, possibility of, maybe some axon loss. And the other kicker here is they tested off of the supraspinatus, but they stuck the infraspinatus. So they didn't even stick the same muscle that they, recorded off of. So this, again, this is a big turd. Right here. Okay, this tells us nothing. And when I asked, they said, well, it was normal. I said, well, how do you know it's normal if you haven't done the other side? Or you didn't stick it? And they go, oh, I don't know. Okay. So, this is a big no-go. Couple more of these guys, and then we'll we'll stop here. This is a median nerve again. Take a look at this.
Yeah, looks pretty good from a technical standpoint.
You sure about that, my friend?
Well, there's a little bit more of an amplitude drop than you would expect.
There is a huge amplitude drop at the elbow. Plus, look carefully at that wrist waveform.
There's some stem artifact.
Got a little bit of stem artifact here.
Little positive.
You got a positive deflection.
Yeah.
That you don't have here.
Yeah.
So why is this amplitude so big?
Oh, you know what? Yeah. Could be getting a little bit of ulnar in there.
Yeah. Probably getting some ulnar. And is this cursor, if taking out the other technical part of this, is this cursor in the correct position?
No, it need to be a few notches to the left.
You're right there. Okay, but large amplitude distally, smaller amplitude proximally, with a positive deflection distally, you're getting volume conduction. This would be a no-go. Okay, so here we have a beautiful H reflex. I mean, man, this is as technically beautiful as you can get.
Except for the cursor.
Except for the freaking cursor is in the wrong position. This beautiful waveform becomes a no-go because of the position of this cursor. Cursor probably needs to be about right there, somewhere about right there. Okay. And the reason that I say right there is you can see where it starts to deflect upwards there a bit. But this is as technically a beautiful H as you're going to see, and they screwed it up by letting the machine put the cursor here. This is my friend, the median H reflex, recorded from the flexor carpi radialis. Here. So what's your analysis of this?
They obviously overstimulated and got the M wave.
This is all M wave.
Yeah.
Yeah, their stimulus was too high to begin with. The H would be popping out, over here somewhere. Okay, and they probably overstimulated right off the bat, blew out the H. The H has never had a chance to come in here, and the machine put the cursor here. Okay, so again, this is a giant turd here. Okay, this is a turd, and this is as technically a difficult test. Those of you that have tried it, this is as technically a difficult test as you can do here. Okay, so this would be a big no there. Let's see if I got maybe one more here, and then we'll. Oh, here we go again. This is another median H. Here, same type of situation. Okay, let's make this our last one here. These are, this is a tibial H. How about this? Would you take this?
Yeah, except for the first two, trace 1 and trace 2. They look
What's
pretty
wrong with
close.
them?
It doesn't look like I can't see the deflections as much with those.
Yeah. You can't see the deflections because you haven't maximized the H response.
Yeah, that's it.
Yeah.
But yeah, it looks good otherwise in my opinion.
Otherwise this looks fine. It looks fine.
You want more of the M response?
I'm sorry. What was the question?
Would you want less of like the M response?
You want to maximize the amplitude of the H, and oftentimes that will require you to get a little bit more M. If we look at the previous one here, you can see how the H keeps getting larger and larger, and then it drops back down with no M here. But in some patients, especially if they're thick, i.e. fat, okay, you're going to have to stimulate harder to maximize the H. And in that case, you certainly could get some more M. But you're always wanting to maximize the amplitude of that H response. If we stopped here when we started to get some M, we would have very small H responses. And we would say something like, oh, this patient's got an S1 redic because the H's are so small. You want to maximize the amplitude of that H, and sometimes that requires that you bring in a little bit more M. Okay, but otherwise, cursor's in the right position. You can see here, how the deflection goes, negative first here, and we saw the same thing here. We saw a little bit of a negative, deflection here first. So this one here, I would put my cursor right there. Okay, this is the last one here now, I promise. So this is another H reflex test.
Those are F waves.
Those are F waves. Why are we getting F waves instead of an H?
Those were supermax.
Yeah,
stimulus.
our first stim up here, we've almost maximized our M response. So the H response is already come and gone. And these are F waves. So how do you fix this, Richard?
Well, you decrease the stimulation.
You absolutely would decrease that stimulation. Correct. Absolutely. And the F's will go away, the M's will become smaller, and you'll start to see the H responses. Good. Okay, so we've been at it for almost an hour and 20 minutes here. Let's go ahead and stop here. Any questions that I can answer while I got all you guys here on the phone?
Dr. Brooks, I think it was the one where you said you were recording off the FDI and you had the ulnar nerve, and you said there was a drop in 19% amplitude. And I know I could probably look it up, but I'm trying to remember, what do you consider to be partial conduction block? Because I know there's some differences sometimes with what people state.
For the ulnar nerve, for the ulnar motor nerve, a greater than 20% change in amplitude from one segment to the next is abnormal. Okay. Now, that being said, if we have this situation, if we have the tibial nerve over a long segment, I want to say that this was around a 30 or 30-something% drop from ankle to popliteal. But again, we have an increase in that duration here.
Right.
If we go back and look at this one right here, you see, guys, we're having no increase in duration here, but the amplitude is still dropped. Okay.
Right.
So that's the definition of a conduction block. A drop of greater than 20% from one segment to the next with no increase in duration.
Okay.
Okay. What's going to happen to the area in a conduction block?
It's going to decrease.
It's going to decrease because X percentage of those axons are not able to conduct through that area of focal compression. They're being blocked.
Good. That helps. Thank you.
Yep.
And one other question for me. Are there any general tips that you can give us on how to become more efficient with our time?
Yeah.
And there while doing these things.
That is going to come with experience and confidence. Okay. That's just one of these things where you're going to pay your dues. Okay. You're going to learn as you become more confident that you know exactly where to stem. Then your efficiency is going to increase. Now, that being said, what other things do I do to help improve my efficiency? So if I'm doing an upper extremity exam, okay, I start with the sensories. I'm going to mark my hand up for median sensory, ulnar sensory, and radial sensory even before I start. I'm going to mark my recording points. I'm going to take my measurements. I'm going to measure my stem sites. And so all I'm doing is I'm doing the median, analyzing it, moving my electrodes, doing my ulnar, analyzing it, moving my electrodes to the radial and doing that. Okay, so so that helps me. That probably saves me 50% of my time by marking up those sensories before I begin. Okay, because I've got the tape measure out. Okay, I can mark my recording points without having to measure. Then I can measure the median, I can measure the ulnar, I can measure the radial, all while I have my tape measure out. If you don't do that, say you start with your median sensory, you're going to measure, you're going to mark your recording stem point, you're going to do the test. Then you got to pull your tape measure back out. You got to mark the owner, recording and stem measure. Then you're going to do the test. Then you got to pull your tape measure out again, and you got to do the radial, and then do the test. Okay, so I found that with upper extremity sensories, I can basically become twice as fast by marking the hand up, before I even do my first stem. Okay, you can certainly do that with the motor also. Okay, and oftentimes I will go ahead and do that as soon as I'm done. I'll mark the APB, I'll mark the ADM, I'll measure 8 centimeters to the wrist, then I'll measure from the wrist to the elbow, or with the owner from the wrist to the below and above elbow, and I'll go ahead and mark them. Okay, and that way I can do my median, generate my waveforms, analyze, move my electrodes to the owner, generate my waveforms, analyze, without having to go back and forth and pull the tape measure out, do it again, stimulate. I've seen some people that in lab, and I'm sure you guys have seen this also, doing a median. They'll stick their electrode onto the APB, then they'll measure 8 centimeters to the wrist. Then they'll shock the wrist. Okay? Then they'll pull their tape measure back out, and they'll measure up to the elbow. And then they'll shock again. And they'll do the same thing for the ulnar nerve. They'll measure, they'll mark the ADM, put the electrode on, measure 8 centimeters to the wrist with the arm straight. Okay, then put the arm into the 90-90 position, measure below and above the elbow. That's what takes the time. I mean, that's what kills your efficiency. Okay, so there are some things you can do to help speed you along, but the most important thing to becoming more efficient is being confident in what you're doing. And when you see something that doesn't pop up, if you see that you're not getting a sensory waveform, rather than spending 10 minutes shocking in 20 different positions, okay, you've already reviewed that patient's history and they're diabetic, okay, or they tell you, yeah, my hand's been numb for 30 years because I worked in a factory. Okay, so you're sort of thinking in advance that, hey, I may have some sensory deficit, when I do my test because of what my differential diagnosis is telling me here. Okay, so again, there are certainly some little things you can do to speed yourself up. Those, along with having confidence in what you're doing, are the two big things that are going to help your efficiency. And the best electromyographers in the world are all going to tell you that it really takes a good 12 to 18 months to really get comfortable and to start to really get, efficient. Okay. And, again, you've got to be watching what you're doing all the time. You've got to be analyzing your data as you go. Okay. And, because there's nothing worse than having me, say, yeah, bring them back in and do it again. Okay. Because, you've got a very low CMAP for that median nerve off the APB, but your needle EMG was normal. How's that possible? Okay. That's just not possible. Okay. There's other things. There's other little tips. Low snaps and low CMAPs. Okay. If you get a low snap amplitude, automatically you're going to check that same nerve in the other limb. Automatically. No ifs, ands, or buts. Got to do it. Or you get a no response, you're going to the other limb. Okay. If you get no response in that limb, then it's very possible you might end up doing a third limb. Okay. Motor CMAPs, a low amplitude motor CMAP. If that amplitude is low, you absolutely positively are going to stick it with a needle. Okay, because what causes a low CMAP other than technical error?
Axonal loss.
Axon loss. So you stick a muscle that's lost its axon, what are you going to see?
Fibrillations, positive.
You're going to see abnormal spontaneous activity. You're going to see abnormal motor units, and or you could see abnormal recruitment. If you have a low CMAP and your needle EMG is completely normal, guess what? You're not dealing with axon loss. It's either something technical or it's a conduction block. And I see that a lot when we record off the APB and we shock at the wrist. You know, a 3 millivolt CMAP. You know, 3 millivolts at the wrist, 2.8 at the elbow. But the EMG is normal. How's that possible? Okay, and what you're going to learn and what you're going to be taught is when you see that, presentation, when I see a low CMAP amplitude for the median nerve at the wrist, I'm always going to shock that median nerve in the palm. And if it's truly an axon loss, that amplitude's not going to get larger. If it's a conduction block, that amplitude's going to become normal. And in that case, you might see a normal EMG. But if that amplitude is low in the palm, you're going to see some sort of abnormality, on that EMG. If it's very chronic, you could see some fast firing motor units. You can see a reduced number of functioning motor units. You may not have any polyphasics. You may not have any increased insertional activity, but you're going to see something. Okay. So all those things are going to figure in to making you more, efficient. Take the time to learn this. 12 to 18 months. I mean, would anybody out there that's been doing this for a while disagree that it takes some time to get really good at this?
I think
hard for me to say on that one.
That is that humble component when you feel like you got it down. Like I had an issue last week where I thought I had it down, but sometimes you need that humble pill too to go back.
Oh yeah, and then you get kicked in the face.
You're not as good as you're not as good as you thought you were. Let's put it that way.
Yeah, I saw a case last week, and we're going to have to wrap this up here in a couple minutes because we're about out of time, and it'll shut us down. I saw a case, and it wasn't last week; it was before Christmas. A 35-year-old guy with complaints of low back pain, foot numbness, and weakness, profound weakness in his legs. And I looked at his MRI, and his MRI wasn't that impressive. I mean, he had a couple of bulging discs. So when I go to get him, dude's walking in on a walker. I mean, 35, 36-year-old guy. He's walking on a walker, and his wife is having to help him. And I'm thinking to myself, you big piece of crap, okay? Coming in here, on a walker, walking stiff. I mean, he was walking so rigid. Basically, his knees were locked when he was walking. And so, I get him on the table and I talk to him, and, he's a little whiny, do his nerve conductions. He's got a little bit of polyneuropathy. Then I go to do, and his MRI showed disc bulges at L4-5 and L5-S1 with mild bilateral neuroforaminal stenosis. Okay. So I stick his, he's laying on my table. I stick his quad. I stick his vastus medialis. It is lit up with fibs and positive sharp waves.
Huh.
Right then and there, I'm going, oh crap. So what was the next muscle I stuck? do you think, while I had him lying on my table?
A glute or the paraspinals?
I went and stuck his other VMO, and it was lit up.
Huh.
With him just laying on the table, what was the next muscle that would be easy to stick? That you think I might have stuck? Went up and stuck his deltoid on that right side. Deltoid was lit up. Whole screen full of fibs and positive sharp waves. At that point, I'm going, holy crap.
This guy's got something.
This guy's got ALS.
Okay, I knew it was some kind of big disease. I just didn't know which one.
Yeah, and I'm thinking to myself, Brooks, you're a good Christian guy. How can you justify to yourself thinking that this guy was a giant turd? Okay. So I went and stuck his upper trap. It was lit up. Okay. And then right then and there, I'm thinking, this is all of a sudden going to become a 4-extremity exam. Okay. And I'm going to have to stick proximal and distal muscles in all extremities. I'm going to have to stick his, thoracic paraspinals, and I'm going to have to stick his tongue.
Whoa.
Okay. And his tongue was lit up also. Okay. Then, and this poor guy knew something was going on, because he come in to have his legs checked for, to rule out a radic, and I'm sticking his freaking tongue. Okay. And he's going, what's going on? And I lied to him. I said, well, I'm not really sure, which sort of wasn't a lie, because I'm really not sure what it was. I mean, I know it was a motor axonopathy, but I wasn't sure that it was ALS. I mean, it could have been something else there. Okay. And so again, it's every single muscle I checked on this guy was lit up. Every muscle had increased insertional activity. Every muscle had fibs and positives. Completely normal motor units, though. Okay. So again, it's just, there, getting back to your comments there's, when you let your mind take you somewhere where you don't need to be going, oftentimes, you'll get punched in the face. And this was, this guy probably has, ALS. I went and, why do you think he was walking so rigid?
Because he can't activate muscles.
Yeah, and he was spastic. I mean, the guy had clonus. I went back and did a better job of checking his reflexes. He had brisk, uppers and lowers. He had a positive Hoffman's test. The guy was weak, and the guy was rigid. If he didn't lock his knees and if he didn't use that walker, he'd be on his face. So that was a morning. And this happens to me, a couple 3 times a year, that I'll get a case like this, in which 35 or 36-year-old guy, and I've looked at his MRI and it doesn't really show that much, and I go to get him and he's on a walker, and I'm going, I'm thinking that the guy's a giant turd, and then come right around and punches me right in the face, because this guy probably has a condition that's going to result in his death in probably 2 to 3 years. I hope not. I certainly hope not. So anyway, guys, any more questions I can answer while I got you on the phone?
Oh, thank you.
Thanks for your help, Mark.
Yep, guys.
Thank you, sir.
Anytime, if you have questions, call me. Shoot me a text. Ben, I had clinic all day, so I didn't. I didn't get back with you. I've got some time available tomorrow. If you want to talk about that case.
And I redid that case, and I redid the whole thing. So
Okay. So you take a look at your schedule, and maybe we can talk tomorrow. Then.
okay, all right, sounds good.
Okay, guys, sounds good. Take care.
Take care. Bye.
Bye bye.